Good morning. This is Phil Schauer at Cleveland Clinic in Cleveland, Ohio. On behalf of Steve Wexner and Adrian Park, I'd like to welcome all of you to this edition of Innovations in Surgery. Dr. Adrian Park at Anne Arundel Medical Center in Maryland has an outstanding program prepared for all of you. But first, I have just a very brief announcement, and that is Innovations in Surgery beginning next month, January 2018. We'll be using a slightly different bridging system. We would like to thank Chorus Call, located in Pittsburgh, Pennsylvania, for serving us for more than a decade in Innovations in Surgery, but due to an internal reorganization process here at the Cleveland Clinic, we will be actually managing that bridging system with our Cleveland Clinic system. We'll be sending out notifications to all of the sites, specifically to all of the technical support folks who will be coached on how to make the connections in January. The program otherwise will go as it has been for the last several years. We'll be continuing to bring to you top speakers and innovative subjects to enhance your educational experience in surgery. So more about that program to follow. Now, without further ado, it's my pleasure to introduce Dr. Raymond Price at the University of Utah, and he has a very innovative and different sort of topic to present today, and that is the new world of surgical innovation, frugal, reverse, and extremely affordable surgical care. So, Dr. Price, welcome. So glad to have you here today.
Great. Thank you so much for having me. I hope everyone can hear me there. I was quite honored to be invited to speak to this group. That is until Adrian Park said that I would be speaking at 4:45 a.m. Salt Lake time, but it still has been an exciting opportunity to come and participate in this. I'd like to go ahead and just begin with my next slide there. One of the greatest challenges to medicine today is to find a way to provide adequate medical and surgical care to the 85% of the world's population who now lack it. This is a real challenge. And as we look at developing products and even just affordable health care, the University of Utah, we went ahead and developed a Center for Global Surgery. Our Center for Global Surgery really looks at the questions of how do we provide access to affordable surgical care worldwide, both in the low resource areas as well as the high income areas. The challenge is most of the products that have been developed, in fact 90% of the products and services that have been designed and engineered benefit really only 10% of the world's population. As we go around the world and work in many of these places, the world is becoming much more flat. As you go over to Nigeria, you will have people that have cell phone access throughout the country. They have internet access, and they see what the rest of the world has, and they really are beginning to demand to have the same kinds of services. Dr. Akipori in Nigeria said, as we now live in a global society, it would be unconscionable for Nigerians to be denied the medical advantages of new technology. Well, that's a wonderful statement. When we think about the various areas of surgery that we try to provide around the world, there's many challenges that face us of how to proceed with that goal. You know, there are many obstacles when we look at for orthopedic surgery, urologic, obstetrics, pediatric, cardiac, the whole spectrum of surgical care. We all use pretty much high quality, high technical kinds of equipment to be able to do what we do, whether or not it's laparoscopic surgery, orthoscopic, robotic. But the challenge is we try to figure out how we do this. I was over in Nigeria at one point, and I found that there was a healthcare company that received the award for the best healthcare company for that year. When you go to their website, what was the way that they provided the health care? This is exactly what it says on their website. Medical tourism offered by MHL is a solution to today's need of an average Nigerian for whom the medical treatment to Nigeria is not encouraging for life-threatening diseases. And if you look at the map there, what they're what their solution was to send people from Nigeria over to high-quality hospitals in India. Fuimu Nikuar from UT Southwestern took this to the Minister of Health in Nigeria to really show them that they have a significant problem with health care in their country if they're having to send people outside. So the question is, how do we develop this in these kinds of countries? Many people seem to put in a wastebasket this word low and middle income countries. And that seems to indicate that maybe they're all the same. But as you can see, the country income levels are different. There are low-income countries. There are low-middle-income countries. There are low or middle-income countries. All sorts of different levels of income that people can have maybe different resources to be able to develop products and ideas. So that while we may not be able to develop immediately at the lowest areas of the world, there certainly is becoming an opportunity to focus our abilities to develop products onto maybe more affordable areas that not only would help these low middle income countries, but maybe could come back and help our own high price system become much more affordable. As we look around the world, business markets in rural areas previously thought to be unattractive financially are proving to be a realistic source for economic growth, both locally and abroad. And the picture on the left side is just a picture from a small town in Mexico where there is this is a microeconomic banking program. Notice that really it's just the women that are there. There are no men there in that group. But this is a microeconomic banking program. It's not uncommon to really be run pretty much by the women. On the right side, low-cost computers being able to hook up to internet in many resource poor areas, really expanding the abilities for growth. Still, we're faced with many challenges. Some of the challenges are just human resources. And some people say, well, geez, even if we develop the products, there aren't people there to be able to use the product. And again, that's putting everybody into just all this low middle income country basket. And so while, yes, it is true that in Africa, we just don't have as many healthcare providers, or at least surgeons there. There are a variety of types of healthcare providers, and our focus in developing products sometimes targets not just surgeons, but again, trying to figure out who can provide these services. Can we develop the products in a way that allows them to give services further on? At the University of Utah, we came back from some of our work around the world, and I met with the dean of the engineering school and asked the question, can we begin to work together to develop products that make surgery more accessible and affordable in these areas? And initially, we were sent over to the head of the bioengineering program, whose comment was, well, there's just no business model for this. Clayton Christensen, a good friend of mine from Boston, wrote the book, The Innovator's Prescription. And the elements of disruptive innovation that he shares are, you do need to have this sophisticated technology that simplifies. And we were working on that, and what we were told from the engineering school was, well, there's just not this innovative business model, the lower triangle on the left. And then we had to start looking at, well, is there an economically coherent value network? And as we try to develop these products, how do we get them into these areas with all the different regulations, standards, and either facilitate the change or block it? To get them to understand the concept, we presented them the story from the Himalayan Cataract Project. Dr. Jeff Tabin was an ophthalmologist here at the University of Utah, and he, with Dr. Ruit, began working on an ophthalmology project back in the 90s. There in the Himalayan region, blindness is a death sentence. People long thought that as you grow old, your hair turns white, your eyes turn white, and you die. Well, they thought this wasn't right. In the Himalayan Cataract Project, they redesigned a sutureless technique to put in a lens. They then developed a $4 lens. They then built a business in Nepal that mass produces these and set up a training program to train people how to put in the lenses. And then over the last 20 years, they have been curing blindness all over Central Asia, and now it's moving over to Africa. It was with this kind of concept that the head of the bioengineering department said, let's look into this further. So as we begin a program, there was a program starting at the University of Utah at that time called Bench to Bedside. It also, as we developed our program, we then developed a program called BioWorld. And part of that BioWorld program was taking the engineering students with us out to the various countries we were working, such as Mongolia here, take them out and see the resources that were available and what was needed in these areas. So we could develop with the people in the countries products that might be beneficial to them. One of the first things that we identified was a difficulty having appropriate operating room light. And so our teams came back and we had multidisciplinary teams begin working on trying to identify a way to build a low-cost, high-quality operating room light that had the same lumens as the light that we have here in our hospital here in Salt Lake City. It had to be sustainable. It had to be simple, easy to adjust, manipulate in a sterile environment. And so our teams began to work on this, and we were really pretty excited. They won an award for $10,000 to help move this forward. It began to take off into even a small little business. They developed a website. We looked at this. We met with various business people, and if you can think back to the triangles that I showed with Clayton Christensen's book, we were really very close to developing the low-cost product. But we hit a block with developing the business model to move it forward. This Illumed Global really was partnering with low-resource countries to bring them higher quality health care, taking it from development with the people there at the bottom of the pyramid, is what BOP meant, into these hospitals. And this was a mock-up of what this light looked like. But we had difficulty trying to find the business model to go forward.
I want to go for a comment, please, to our friends at Imperial College in London. Morning, gentlemen. I know you guys have a deep experience in frugal innovation and really innovation of every stripe there. Can you just tell us a little bit about, and we're going to hear more about this from Dr. Price in a sec, but can you tell us a little bit about how your innovation, a little bit about the European approach or your approach, if you would, to innovation. What's your market? Who are you looking at? And the second part of the question is there any way that you have connected the concept and your work and your institution on global health, global surgery, with your innovation program?
Good morning. Thank you for coming to us. We agree that with the comments previously that a lot of our innovation is focused on very high cost sort of technology, and we have started to move away from that as well within the department. We've begun also to start looking at Africa as a potential model for opportunities to help improve the quality of healthcare in other countries and also bring it back to ourselves. There was actually a presentation a few months back from our department internally about some work done with an iPhone about looking at basically being able to look at the back of the eye for patients with eye diseases in Africa, and with very low-cost software on the iPhone. And we're actually starting to look at bringing some of these technologies back into the UK and the European market as well. But we are exploring this area. It's not somewhere I think that a lot of institutions have a lot of experience with. But it's certainly a very interesting area for decreasing costs as well in Western countries.
Yes, and thanks for those comments. And I think we're going to hear some more very kind of stimulating ideas from Dr. Price in a minute, and recognize that this concept is not necessarily just the right thing to do, but there's actually a tremendous market out there for this. So, Ray, let me hand back to you if you would, and continue with the presentation.
Great, thank you very much, Adrian. So, the first part, I brought up the idea of really low-cost and frugal innovation. Is this really possible? And initially, we were hitting some challenges, and so I'm going to share this next story, which is specifically about one of the areas that is really taking off, that is helping us, I think, move things forward. The treatment of gallbladder disease around the world is really different. In most of the high-income countries, we're treating it with laparoscopic surgery, whereas in the low and middle-income countries, it's still treated with open cholecystectomy quite frequently. So the benefits of laparoscopic surgery actually elude much of the developing world. Now, there have been many people, as we look at this, really question, should we be doing anything there? We're handicapped sometimes by preconceived notions, such as some people say surgical care is too expensive to implement in low middle income countries when competing with other types of interventions to improve health. And we've been able to show over the last many years that this really is not true. There's many ways that surgical care is actually very affordable in a public health sense. When we look at laparoscopy, next slide, and look at the current use and need of minimally invasive surgery around the world, about 7.5 million laparoscopic surgeries are done worldwide, and 90% of these cases are performed in the United States and in Europe. But as you look at the world, there is currently 30 to 50 million cases per year additional unmet need in the developing market. How do we provide the care in that kind of market that's going to be affordable to make things available? I had no concept of how this might be possible. In fact, I kind of had the previous view. When I first went to Mongolia, thinking, God, there's no way you could do this here in Mongolia, until I was given a PowerPoint presentation in 2005 and told about Dr. Buck Rusher, who came from the U.S., and worked with Dr. Ganbold and Dr. Nimhu and Dr. Okandaya. And he brought them over to the United States and for a month taught them laparoscopic surgery. He went back and worked for a few years. They started laparoscopic surgery together. Of course, after the first one that they did there, they went out for a celebration dinner. They all got food poisoning, and Dr. Okandaya actually died. So it was quite a challenge. So that, when I came in 2005, despite Dr. Nimhu and Dr. Buck Rusher working their best, only gallbladders were being removed laparoscopically, and only in the capital city. When I came there as Dr. Segerlin, the chief of surgery at the Health Sciences University of Mongolia, who gave me this PowerPoint, and one of her slides said, Introduction and further development of laparoscopic surgery in Mongolian surgical practice is demanded. They were a nomadic people. They had a high rate of gallbladder disease, but there were many challenges. I really wondered, could this be possible when you look at the world without power? You look at the electrification right here, and you can see Mongolia up on the right upper side is very dark. We have problems with power. Just even access to clean water sometimes is a challenge. Here is Erdenet, the second largest city, where the people are going to the well to get the water. And there are some bigger modern buildings in the city, but most of the city is like this. When we were out in Avakir trying to develop laparoscopy, this is our team. When all the water went out, the electricity went out. But I noticed also the ingenuity of the Mongolian people, because the operating room was on the fourth floor. They took out the longest extension cord I've ever seen, threw it out the window, hooked it up to the generator in the back, and we had electricity back on. And then water, they were prepared for that. They brought out these bowls that my scrub tech is scrubbing in, put alcohol in it, lit it on fire, and then poured still water they had sterilized before, and we continued moving forward. So the question isn't, should it be done? The question is, how can we make it happen? In Mongolia, our initial attempts were to develop 39 different hospitals with improving their resources. This was done through multiple donations from multiple companies, Storz, Covidian, companies around taking reused equipment and then brand new equipment, developing an education model, and then developing a multidisciplinary education team to teach in multiple places around the country. And through this, over the 12-year period, using high-tech, expensive method, we were able to expand laparoscopic surgery from 2% of the gallbladders to 2011, when laparoscopy became the primary way to remove the gallbladder. And actually now it's up to about 80% of the gallbladders being removed and open cholecystectomy going down. Our teams have taught in the maroon areas. Our students have taught in the blue areas in the map there. The yellow areas are the only remaining areas that do not have laparoscopy available. It's in 17 of 21 provinces. The real question became then, these companies are not going to give all their equipment away for free for the rest of the world. It's just not going to be, it's not a sustainable business model. So the challenge is really extreme affordability, and how do we design quality laparoscopic equipment to work in these areas? The picture on the left here is looking out of the hospital window at from the Holt Hospital in Western Mongolia. come back to the University of Utah with our bench-to-bedside projects. We looked at the light source, we looked at the camera, we looked at the scope, and together, finally, Dr. Langell brought a bunch of our groups together and developed what they call the Zenescope. It is a laparoscope that is combined with the laparoscope, the light source, and the camera, using cell phone technology, using an LED light system. There's no fiber optic thing. The platform works independently of any monitor. There's no tower necessary. The battery power can go up to 11 hours. You can hook it up to an iPad. That's actually a picture from the Zenescope there. It's high definition now. Early on, this was the early prototype that we were going forward with. It won a TCIP grant, a NASA travel grant, placed second in the Grow America competition. And it's moved forward so that we then got FDA approval. We did usability testing in rural India. The picture on the right is using the iPad as well as the big screen to show both could be used well. This was for sterilization there. Then the next thing was to try to take this to an area where we were doing laparoscopic cholecystectomies, and Mongolia was our site where we've been working. We went through all the regulatory approvals, and again with FDA approval about 2 days before we started our course there. It was approved for at least a one-time use, and we began to do our cases with 21 cases using this low-cost technology there. We were able to look at this and really try to get a little bit of information, and for some reason the slide's not showing up very well there, but the visualization, the ease of use compared to theirs, and what they use, it was all very favorable. This is something that they actually now in this area keep asking for more because they go back to their old equipment and they can't see very well. And they would like to use this low-cost laparoscope all the time. One of the things that we did a year ago, September, to really show its usability, we went ahead and took the tool and we broadcast live from Mongolia, from an outer place in outer Mongolia, to 44 countries that watched it live using virtual reality. And they could see the wonderful picture that we had there. We had people calling in from multiple countries around the world. Wall Street Journal picked it up. And again, while this is a low-cost tool, maybe it could help patients in the third world. Could it help our own people back here? So we're currently in our IRB protocols examining this at the Intermountain Medical Center and at the University of Utah. And so we had a team over there just a few weeks ago using now the 30-degree scope that has been developed. And again, we're finding that in Mongolia the scores are extremely high. And the five different graphs here are some of the trials from Intermountain Medical Center where, well, comparing it to what we have, which is the high-end storage equipment, still there's some challenges. This is on older version of our scope. We have a new scope out now that we're starting with a 1080 DPI that looks like it's really getting to the point that really might help disrupt our high-priced, expensive system here.
Great. Thanks, Ray. Are you able to, before we go to comments, are you able to, what's the ballpark of where you think this, the cost of this scope and you know, where it might sell for?
Excellent. Yeah. So we've been looking at really where it might sell for. Currently, the FDA approval is for a disposable device. If it's made in large quantities, the device itself can be made for about $85. It has a dongle that costs more to make. So the dongle is a reusable component, whereas which connects the laparoscope to the electrical source there. And so they're looking at what is the appropriate price to have that. And then they're also making it so that, well, can it be used more? Right now it's approved for a one-time use. We've stressed that what we need to do is have a device that could be used 25 times, and that then the market price for that, even if it's $2,000 for that, if you could use it for 25 times, makes that an extremely affordable device.
Fascinating. All right, well, let's go to EarCAD Strasbourg in France and to Dr. Swanstrom. I think we've only got audio with Dr. Swanstrom. Oh, no, we've got, there you are, Lee. Good morning or good afternoon, and thanks for making the time to come to this. So folks may not know that among the many hats you wear, Lee, you're the Chief Innovation Officer of the IHU in Strasbourg. And so Couple of questions to you. First one is, so do Stryker and Stores and Medtronic need to start shaking in their boots? Is this part of the future of innovation?
Well, I think it's part of the future of innovation. I think there will always be a span of high tech. High tech tends to be kind of the point of innovation, if you will, and then it becomes more democratized as it bleeds down. I think we needed Storz to invent the HD laparoscope that we all use, so that we can now introduce competition into the market and create something less expensive. It's kind of a normal evolution of business. I think here one of the things we're interested at, one of the problems, of course, with all this is it's very easy to think of ideas, and Dr. Price mentioned this, very easy to think of these ideas for frugal innovation and very hard to create a viable business plan, especially in the United States, I would have to say. In the U.S., as you know, companies typically spend between $5 and $40 million to generate a startup. And if you have a profit margin on a device that's pennies, it's just very hard to do it. So I think one of the missing components for frugal innovation is actually having some novel business plans that would let things be done for less money. It's one of the things we work on here in France. One of the interests the French government has was to fund incubators like the IHU where I work that maybe can bring products to market for $1 million instead of $10 million. And that would give us more latitude to produce low-cost, low-profit margin devices. I think the other impediment is investment, raise money for these kind of products. Investment, especially venture investment, is only interested in high profit margin, massive, small numbers and high return type of devices, $40 million a year revenue streams. And so it's hard to raise money for these kind of ventures as well. But I imagine Dr. Price will comment more on that.
Mm-hmm. Wonderful. Thank you very much. Very, very interesting comments and helpful comments, Lee. Let's go to our friends up in Halifax, Dalhousie University. Wanted to get a sense a little bit about how the innovation culture in your institution has evolved, and have you any experience with seeing concepts coming back from a lower resource setting that you guys have looked to develop? It's obviously an unusual, that would be an unusual way to do it, but interested in your experience. Good morning, Jim.
Good morning. Thanks, Adrian. Jim Ellsmer here. And thanks for Ray for doing a very compelling presentation. Do we have any experience to bring kind of a product from the low-income country to market? I would say no. I'd say I've been involved with our surgical development team at the School of Biomedical Engineering for years, and like most things, it's focused on understanding the U.S. market, and there's been several startups and a number of startups that have been successful in that area, but not necessarily the other reverse pathway that we're discussing today. And I think it's interesting to understand the challenges. I go back to Ray's comment about the solution of the generator outside and running the power cord up to the X-ray, and that's actually the same design that I use currently in my house for my garage door opener. Is running the power cord, and I was reading the other day where that's not the code, and if my house burns down, I've got no liability. So it's the same sort of thing. It's a solution that hasn't passed through any kind of regulatory pathway, seems good until something goes wrong, and depends where you're and how much litigation's involved and stuff. So it's and Lee brought this up, the idea of the cost for a startup, but I think and then we all appreciate it, but it's just worth articulating it for the learners anyway, that kind of the cheapest pathway, regulatory pathway in the United States is, you're talking about $30 million to bring a product to market, and that's kind of on the low end. And so even if you're going to reintroduce that product to this market, you've got to have a business model and that's where you get into this challenge that Ray brought up about, okay, now we're talking about disposable devices, and because that's the only way it makes sense to bring it to market is with disposable, but we want to use it reusable, and we all know that you can run a power cord for your garage opener. It makes sense to do it, but it just doesn't make sense from a regulatory point of view. So so it's interesting. I mean, the other thought that comes to mind when I'm listening to this conversation, I remember when I was a fellow in Boston doing therapeutic endoscopy, we had a lot of observers from low-income countries that were at our place, and every device that we used, they would take it, and when they left, when they went back to their country, they had bins full of devices that we'd used once, and they would clean them, sterilize them, again without regulation, and use them in their home market. But there's lots of things you can do when you don't necessarily have as tight a regulation. So it's an interesting question about it's a balance of regulation versus reality, and every market is different in that regard.
Okay, thanks very much for those comments, Jim. Ray, we're going to head back to you and have you continue, and maybe through the course of this next section, you'll hear the questions about the viability and the need to still adhere to some kind of regulatory pathway and have a business model that makes these concepts viable. Obviously, this is something that you have thought a lot about, and your center in Utah, and at the very end, you got to give a plug for your Extreme Affordability Conference that's coming up as well, where these issues are discussed all the time.
Great, thank you very much. Those are fantastic comments, both of those, and things that I think we all need to consider. And that's why I think that triangle from Clayton Christensen is extremely important to understand on not just the technology, but the business model and the coherently need within the country to even have those and the regulatory issues. Separate from my slides here, what really got us started that this might be possible is a friend of mine who's an endocrinologist here that developed a low-cost way to test for neonatal hypothyroidism when he was working in Kenya. That he then developed for Kenya, brought back to the United States, and became a very viable company called ThyroCheck, which was then used by many hospitals around the country to be able to test for neonatal hypothyroidism. And so that's one of the examples we use in our book of Global Surgery and Public Health, The New Paradigm, when we talk about disruptive innovation. Well, here at the University of Utah, as we begin to develop further products, the University of Utah is actually, I think, have more companies coming out from the University of Utah than any university right now. But that challenge is a big challenge of how to form that business model. So here are a couple other examples that we've looked at. Let's take cervical cancer, for example. The idea came forward that, due to great treatment in our country and high-income countries, the incidence in developed countries has been reduced by 75% for cervical cancer. But cervical cancer continues to be the leading cause of death in the developing world. Over 530,000 women with this. So the problem is, can you identify this lesion early? Can you identify it as a carcinoma in situ? And all of us know that there's very easy ways to identify that through screening. And there are three major ways of treating this and addressing this, both with this loop electrosurgical excision procedure called LEAP, or a cryogenic or a thermocoagulation treatment. And the LEAP is the most common, and it usually costs somewhere around $4,000 to $15,000. But this also requires this reliable power grid, service and maintenance, and anesthesia services, and it carries an increased risk of preterm delivery. So this actually was is one of the ones at the University of Utah that over just a very short time period moved this forward. The idea is using the thermal coagulation method, can you develop a low-cost device that doesn't have any effect on fertility? It takes 1 minute to treat and is very efficacious. So this device actually, as they've worked on it, shows an efficacious carcinoma in situ level 1 and 2 treatment of 96%, level 3, 95%. It's portable, it's reusable, it's inexpensive, it's battery powered. It's actually it doesn't have to be used just by a gynecologist or a surgeon, but here in the picture here, as our trials over in India, we're working with nursing groups to be able to identify the carcinoma in situ and then apply the treatment. This is the one that had a very rapid development timeline, an accelerated program that went from the problem being identified to about 15 months later, having FDA approval and being clinically trialed. You can see the production timeline of the various parts of this device where the housing took the longest time to try to develop. Initially, they called this the Sinluma device, but currently this is called the thermal coagulator. It's gone off into a company that's listed here as well and features FDA 501(k) cleared, battery-powered, portable, handheld, practical, and easy to use for the treatment of pre-cervical cancer. Currently undergoing more trials with the WHO, has been used on 4 different continents now, and is continuing to undergo trials here at the University of Utah. Another example would be a small company that's come out called Wacian, W-A-C-I-A-N, that's working on a company focused on improving global health care. And maybe I should make mention, the bench-to-bedside products and programs initially were targeting the high-resource areas. We started a program called the Extreme Affordability Conference that we bring in business, medicine, surgery, public health, social work, engineering into one conference to try to figure out how can we make this happen. And we've had an exponential rise in the kinds of products that are being developed for these low resource areas. What they were targeting is a need for low-cost vital sign monitoring for low and middle-income countries. So 5 billion people lack safe and affordable health care. Global unmet surgical need, 143 million people with 70,000 ORs that lack basic monitoring. They were able to kind of do an evaluation and see what really was needed. Okay, so they tried to look at where is there a gap in what's needed around the world. There is this an area that was in the left upper quadrant here that was low cost, needing for high patient risk. So they developed this pleth gap, or pleth patch to fill this gap, which is a device that can just attach to your skin, and it can then go ahead and give the information off wirelessly. And so it's a way to do vital sign monitoring that adds patient safety, minimal added cost. It provides continuous monitoring, wireless mobility, low capital investment, and low cost burden. It's built on technology similar to a razor blade. You have your hard chassis and then your disposable parts. And so the part that actually connects to the patient is about $3. The parts that have the electronics, about $70 for this device. This company estimates a worldwide need for this, not just with surgery. When you look at the multiple areas that this could be used in terms of prenatal health, childbirth, the emergency trauma, they estimate a 4.38 billion market for this with a 6.6% growth rate. Is that really realistic? This is what they're predicting. I think there's a need out there, and there's an opportunities for this kind of device. So in summary, yeah, the devices we're trying to develop are ones that we trying to figure out a ways to provide affordable health care. But it's not just device design. It's the business model that's going to support it. It's the regulatory areas that we have to work within. And I totally agree. We need to find the ways that we can get products out there for $1 million for development rather than $50 to $100 million. And then maybe we can end up with the Zenescope or the Sinluma device or the pleth patch. Because I think the real way forward is to stop saying, well, it can't be done. It's the best way to predict the future is to go ahead and create it. Let's make it happen. We've been putting on this course called the Extreme Affordability at the University of Utah for the last many years, which is a multidisciplinary approach to trying to develop these products. Our teams are mixed with engineers, business, surgical people, as we're trying to develop these into products. So we do try to address all those issues. We've gone ahead and worked towards moving this conference to Ghana this year so we can get the ideas from the people on the ground, from the countries where these are being used. There are great devices being developed in these countries as we travel around. We invite you to keep an eye out. This is just to save the date for July 8th to 10th, but we'll be asking for abstracts and things to be able to be presented at that meeting in eastern Ghana, Pong, Ghana, at the Ensign College of Public Health. Thank you very much for having me this morning, and I really appreciate this. It's been a fun opportunity.
Thanks so much, Ray. And before I go out for just another comment as we wrap up, can you just expand a little bit on the cervical cancer device? I saw it in development with you guys a while back, but I'm interested, and I'm sure other members of the audience are, in how you actually settled upon that. How did you settle upon that, or the team settle upon that, of the so many unmet needs out there, that this was the one you were going to focus on? Was there a necessary coming together of a core clinical expertise within your institution and a core engineering capability? How did we look at that and think, wow, what a great idea, and it looks like it's going to be a wonderful success story for you. But I'm sure there were many other ideas that littered the pathway that didn't go anywhere to get to this one. So can you tell us just very briefly how you settle upon that one?
Great question. So let's talk about reality. So I shared initially like our light source product. That one has never been able to take off to be a business. We couldn't find the business model to support that one initially. As we looked at this, at the problem with cervical cancer, we have ideas that we sit down with actually a group of students and faculty and present many different ideas and possibilities. We have clinicians that come in and present some of the ideas. Some of these ideas are picked up, and this is one that actually there was not just a faculty person, but a person who's very interested in women's health, and also had set up some other businesses and became quite interested. So he became the Center for Medical Innovation partners students with actually not just faculty, but people who are interested in certain areas as well that can really help try to bring in not just the device design, but also the business model, as well as the humanitarian component of what we should be doing about addressing a huge need. And so this one caught the interest of actually the director of our Center for Medical Innovation, also his daughter, and also these other people, as well as the students, that really was one that they thought was very interesting and really took off.
Always such interesting stories. Thanks, Ray. Let's go for a final comment just up the road to Johns Hopkins. And I think Dr. Adralis is there and maybe some colleagues. And Gina, what's your experience at Hopkins in terms of opportunity for innovation, for identifying needs, whether locally or abroad, and setting about to create solutions? Now, I know that Hopkins does a lot of really high-end stuff, the really expensive pharma stuff, and that kind of gets a big focus through your innovation and development program. But what have you found, or what's in evolution you can talk to us about from a surgical standpoint at your institution?
Thank you, Adrian. That was a wonderful presentation, and we're very impressed and applaud Dr. Price's work. So Hopkins has several areas where surgeons and other physicians can partner with our engineers, and I think that is a start of a breeding ground where there's this multidisciplinary approach. A lot of that is with our applied physics lab, but we also work with the majority of the engineering school with the CBID projects, which help people bring things to light. And as you noted, a lot of these are sort of higher end technology things, which would be more marketable in the United States and other developed countries. But there's a lot of interest in helping globally. So our international office we partner with a number of different hospitals around the world, and the approach there is sort of teaching, sort of partnering with programs on the ground to help them develop their minimally invasive programs, bariatric surgery, and other areas. But also the focus is on quality and patient improvement. So we often work with hospitals to help them in terms of monitoring their patient safety and figuring out ways to improve and to sort of streamline the care to make it more affordable while maintaining the value of care for patients.
Mm-hmm. We're all kind of, I think, trying to find our way, and it's interesting how different institutional histories and cultures inform this. And I think, again, the whole field is the richer for it. There's no one way to do this. We've run a little bit long, and I want to just I'm going to hand back in a sec, but I want to thank Dr. Ray Price for just such a very compelling presentation, and once again, Ray, for going so far above and beyond the duty, getting up in the middle of the night to present to us all. I think you've stimulated a lot of thought and hopefully some water cooler discussion for the rest of the day.